Welcome to our video on tuberculosis and leprosy. Let's get started. In this lecture, we'll cover two mycobacteria, Mycobacterium tuberculosis and Mycobacterium leprae. Let's begin with Mycobacterium tuberculosis, and we'll discuss the definition, pathophysiology, transmission, risk factors, clinical features, diagnosis, and management. So starting with the definition, Mycobacterium tuberculosis is an acid-fast bacillus that primarily affects the lungs. It enters the host via inhalation of aerosolized droplets and makes its way to the alveoli. As one would expect, this invasion prompts an immune response in an attempt to destroy the pathogen. However, Mycobacterium tuberculosis expresses several virulence factors, which allow it to resist destruction by alveolar macrophages. As a result, the macrophages engulf the pathogen, but are not able to lyse it, allowing it to proliferate freely within them. In the setting of an intact immune system, the organism becomes dormant and remains dormant. In immunocompromised patients, on the other hand, the organism either disseminates or re-emerges from dormancy. A key point to remember about the transmission of tuberculosis from one person to another is that only those with active pulmonary tuberculosis are contagious, meaning those people who are coughing or sneezing. The risk factors for contracting tuberculosis can be broadly categorized into those that increase one's chance of being in close proximity with contagious patients and those that weaken one's immune system. Incarcerated individuals, injection drug users, immigrants, and healthcare workers are all at a higher risk of being in close proximity to patients with active pulmonary TB. Alcoholics, diabetics, cancer patients, and otherwise immunocompromised patients, such as those with HIV or chronic corticosteroid use, all have weakened immune systems, making it more difficult for the immune system to subdue the pathogen and keep it dormant. The clinical features vary depending on whether the patient is experiencing primary tuberculosis, latent tuberculosis, secondary or reactivation tuberculosis, or miliary tuberculosis. Primary tuberculosis occurs following first exposure to Mycobacterium tuberculosis, and the primary clinical feature to be aware of is the Gone complex, which can sometimes be seen on a chest X-ray in patients with primary tuberculosis. Here's a chest X-ray depicting the classic appearance of a Gone complex in a patient with pulmonary tuberculosis. A Gone complex is characterized by a pulmonary granuloma that's associated with ipsilateral hilar lymphadenopathy. Here's the pulmonary granuloma, and here is the ipsilateral hilar lymphadenopathy. This complex forms as a result of the immune system attempting to wall off Mycobacterium tuberculosis from the rest of the body and thus prevent it from spreading further. The primary stage of tuberculosis is typically followed by the latent stage of tuberculosis, in which the organism remains dormant with immunocompetent hosts. Though these patients tend to be asymptomatic, they're still harboring the pathogen, and it's extremely unlikely to go away without treatment. Secondary or reactivation tuberculosis is a progression from the latent stage of tuberculosis that occurs following an insult to the host's immune system. In this stage, dormant tuberculosis can reemerge in patients that experience a state of immunosuppression, as seen in patients taking immunosuppressants, patients struggling with substance abuse, or patients with AIDS. Upon reactivation of tuberculosis, patients tend to first present with constitutional symptoms, such as night sweats, weight loss, or fever. They may also report a worsening cough or hemoptysis, and they tend to have notable opacities on a chest X-ray. Here's a chest X-ray depicting opacities in the right upper and left upper lobes of a patient with secondary tuberculosis. It's important to point out that Mycobacterium tuberculosis tends to reactivate in the upper lobes rather than the lower lobes of the lungs. One thought for this reasoning is that because tuberculosis is an anaerobic organism, the oxygen tension tends to be higher in the upper lung lobes compared to the lower lung lobes, which is why it may reactivate in this region. All right, let's try a question. Which class of immunosuppressants is often associated with tuberculosis reactivation? All right, in real life, but especially on exams, tuberculosis reactivation often occurs in the context of TNF-alpha inhibitors. TNF stands for tumor necrosis factor, and tumor necrosis factor alpha is particularly critical in the formation and maintenance of granulomas that the immune system utilizes to wall off tuberculosis from the rest of the body. Hence, if a patient with latent TB is started on a TNF-alpha inhibitor, the pulmonary granuloma that was keeping TB latent will dissolve, allowing it to reactivate or even disseminate. Miliary tuberculosis occurs if the host immune system is significantly weakened, and it may occur following primary, secondary, or latent TB. In simple terms, miliary tuberculosis is a disseminated systemic infection with Mycobacterium tuberculosis. Although the pathogen may spread to involve any organ, patients with miliary TB typically present with either cavitary brain lesions, signs of organomegaly, infection of the vertebral column, which is known as Pott disease, or reticulonodular infiltrates on their chest X-ray. Here's a chest X-ray depicting the characteristic pulmonary findings in a patient with miliary TB. Note the innumerable pulmonary nodules scattered all over the background of fine reticular opacities, which is so characteristic of this illness. Here's an image of a spleen infected with TB. Note these small white nodules resembling millet seeds scattered all over the spleen. Similarly looking nodules would also likely be seen on the lungs of this patient and the patient from the prior slide. The diagnosis of active pulmonary TB can be confirmed with sputum testing using either an acid-fast stain, also known as the Zeal-Nielsen stain, PCR, or a mycobacterial culture. A chest X-ray is also usually obtained to check for pulmonary opacities. Here's what Mycobacterium tuberculosis can look like under an acid-fast stain. The organisms appear as red-purple rods against a bluish background. Patients with latent or asymptomatic TB can be tested with either a tuberculin skin test, also known as the PPD test, interferon gamma release assay, or a chest X-ray. The tuberculin skin test is a screening tool for latent TB in patients with certain risk factors, which we'll discuss on a subsequent slide. Importantly, the BCG tuberculosis vaccine can lead to false positive results because it contains tuberculin antigens that can trigger a strong enough immune response to cause significant skin induration following the tuberculin skin test. Although this vaccine is not typically administered in the US due to its questionable efficacy, it's often administered in foreign countries, making TB screening challenging in immigrant populations. If a patient has previously received a BCG vaccine, they should be screened using the interferon gamma release assay instead, because the BCG vaccine does not affect the results of this assay. If either the tuberculin skin test or the interferon gamma release assay are positive, it means that the patient is harboring a tuberculosis infection. At this point, a chest X-ray helps distinguish whether the patient has active TB or latent TB. If the chest X-ray shows pulmonary opacities, the patient has active TB. If the chest X-ray appears normal, on the other hand, the patient has latent TB. Here's an image depicting administration of the tuberculin skin test. Tuberculin material is injected under the skin, and the patient is instructed to return to the clinic in 48 to 72 hours to evaluate the extent of skin induration at the injection site. This timeline is critical because if the patient returns earlier than 48 hours, the immune system may not have had enough time to mount a full response against the injected tuberculin material. If the patient returns later than 72 hours, on the other hand, the immune system may have already begun subsiding, which means that the resultant induration would not be at its peak during examination. Importantly, it's the extent of skin induration that is important for the diagnosis, not the extent of erythema or pruritus. For the purposes of the USMLE Step 2 exam, it's important to know the induration cutoffs that are diagnostic of a tuberculosis infection. Unfortunately, there isn't a universal cutoff number, as the number varies based on the individual's medical history. This table summarizes the key scenarios in which the PPD test is considered positive. If the induration is greater than or equal to 15 millimeters, the PPD test is considered positive in everyone age 4 and above. A smaller cutoff of greater than or equal to 10 millimeters is considered positive in healthcare workers, immigrants from TB endemic countries, incarcerated individuals, injection drug users, nursing home residents, homeless individuals, employees of mycobacterial labs, patients at risk for TB reactivation, such as those with diabetes mellitus, cancer, or malabsorption disorders, and finally, children less than 4 years old. An even smaller cutoff of greater than or equal to 5 millimeters is appropriate to use in the setting of an HIV infection, close contact with a contagious person, an immunocompromised state, as can often be seen in organ transplant patients or patients on chemotherapy, and when a chest X-ray demonstrates fibrotic changes consistent with prior tuberculosis. Lastly, an induration of less than 5 millimeters is considered positive only in patients who have an HIV infection and recent close contact with a contagious person, which is a person with active pulmonary tuberculosis who has been coughing or sneezing. This table undoubtedly looks intimidating to memorize, but most of it should make intuitive sense. A 15 millimeter cutoff can be applied to pretty much anyone. A 10 millimeter cutoff is applied to people who either have the potential to work with TB patients, such as healthcare workers, or who have likely had contact with TB patients, such as immigrants from TB endemic countries or incarcerated individuals. A 5 millimeter cutoff is applied to severely immunocompromised patients, and patients with known HIV and a recent contact with a contagious person are pretty much presumed to have TB. Take some time to internalize this table because these diagnostic criteria guide management. All right, let's try another question. A 25-year-old medical student returns to clinic with interpretation of her tuberculin skin test. Her induration is measured at 12 millimeters. What is the next best step in management? All right, based on the information discussed on the previous slide, a PPD cutoff of 10 millimeters is used for all healthcare workers, including medical students. Since her induration is measured at 12 millimeters, her tuberculin skin test is considered positive. Hence, the next best step would be to order a chest x-ray to determine whether she has active TB or latent TB. As a reminder, an abnormal chest x-ray with pulmonary opacities is consistent with a diagnosis of active TB. A normal chest x-ray in the setting of a positive PPD test, on the other hand, is consistent with a diagnosis of latent TB. The first step in management of confirmed active TB is to isolate all patients and use airborne precautions. Next, these patients should be treated with the so-called RIPE therapy, which includes a course of rifampin, isoniazid, pyrazinamide, and ethambutol. Generally speaking, patients take all 4 of these drugs for 2 months and then subsequently just take rifampin and isoniazid for the following 4 months, and this is usually sufficient to clear the infection. One of the most common adverse effects associated with RIPE therapy is transaminitis. Hence, clinicians should monitor patients for the development of mild transaminitis for the duration of their treatment. The management of latent TB is a lot more straightforward. Patients are treated with isoniazid alone for a period of 9 months. A key point to remember about isoniazid is that patients that take it for a long time may develop peripheral neuropathy secondary to vitamin B6 deficiency. For this reason, it's recommended that clinicians prescribe supplementary vitamin B6, also known as pyridoxine, during the course of treatment. All right, let's try another question. What are the most notable adverse effects of RIPE therapy for tuberculosis? All right, as we mentioned on the prior slide, the side effect common to all 4 drugs in RIPE therapy is hepatotoxicity. Each individual drug, however, has a few unique side effects that show up on exams from time to time. Rifampin has a very distinct side effect of causing orange body fluids, such as orange urine, tears, or even sputum. Although this may be extremely concerning to patients, this is a completely benign adverse effect that typically goes away after discontinuation of the drug. Isoniazid can cause peripheral neuropathy due to pyridoxine deficiency, as well as lupus and an anion gap metabolic acidosis. Pyrazinamide can cause hyperuricemia and gout attacks. And finally, ethambutol can cause optic neuropathy. Okay, now let's move on to Mycobacterium leprae. As with Mycobacterium tuberculosis, we'll discuss the definition, pathophysiology, transmission, risk factors, clinical features, diagnosis, and management of leprosy. Mycobacterium leprae is an acid-fast bacillus that leads to either tuberculoid leprosy or lepromatous leprosy. Notably, leprosy is also known as Hansen's disease. The organism preferentially infects superficial nerves and skin because it prefers the cooler peripheral temperatures rather than the warmer core temperatures. Similar to Mycobacterium tuberculosis, Mycobacterium leprae also expresses virulence factors to resist destruction by macrophages, and it also proliferates within them. The key point to remember about the pathophysiology of leprosy is that the host's immune response determines the type of leprosy that the host develops. A strong immune response to Mycobacterium leprae will result in tuberculoid leprosy, and a weak immune response will result in lepromatous leprosy. As far as transmission goes, armadillos are known reservoirs for Mycobacterium leprae in the US and are thought to contribute to transmission. Exact human transmission remains debated. Currently, the disease is thought to be transmitted either via respiratory droplets or skin contact. It's typically seen in either immigrants or people with recent travel to developing countries. The clinical features depend on whether the host develops tuberculoid leprosy or lepromatous leprosy. Tuberculoid leprosy is characterized by hypopigmented anesthetic skin lesions with raised borders and hairless plaques on the patient's scalp. Here's an image depicting the characteristic hypopigmented skin lesion that can be seen in a patient with leprosy. Lepromatous leprosy is a more severe form of leprosy, and it's characterized by a stocking glove neuropathy, thickening and enlargement of peripheral nerves, for example, the ulnar nerve, and the so-called leonine facies, a term that describes thickening and disfigurement of facial features, often making one's face resemble a lion's face. Unlike tuberculoid leprosy, lepromatous leprosy can be lethal if left untreated. Here's an image depicting the so-called leonine facies in a person with lepromatous leprosy. Note the significant disfigurement and thickening of our facial features. The diagnosis of leprosy can be confirmed with a full thickness biopsy of the skin edge, which is considered the gold standard diagnostic modality. That being said, a Lepraman skin test can also be used to diagnose tuberculoid leprosy. This test works similarly to a tuberculin skin test, in that patients receive a subcutaneous injection and are observed for a skin reaction several days later. Since a biopsy tends to yield results faster, the Lepraman skin test has largely fallen out of favor. As far as management goes, tuberculoid leprosy is treated with dapsone and rifampin. Lepromatous leprosy, on the other hand, is treated with dapsone, rifampin, and clofazimine. Notably, Mycobacterium leprae is a tough bug to get rid of, and the recovery course may last months to years. All right, let's try another question. What are the key differences in presentation of hypopigmented lesions of leprosy and hypopigmented lesions of ringworm shown below? All right, since both conditions can present with hypopigmented lesions, it's important to be able to distinguish them on exams. The key difference is that hypopigmented lesions of leprosy will be anesthetic and associated with some form of sensory or motor neuropathy in the nearby area, as well as potential thickening of the nearby peripheral nerves. Ringworm lesions, on the other hand, will not have any neuropathic findings. All right, let's conclude this lecture with a final multiple choice question. A 31-year-old male returns to clinic for evaluation of his tuberculin skin test that was placed 2 days ago. He is an international medical graduate from Indonesia, and he is scheduled to start his medical residency here in the United States next week. He does not report any health problems, and his review of systems is entirely negative. He never received the BCG vaccine, and he denies a history of positive tuberculin skin tests. He denies recent sick contacts. The clinician measures the induration to be at 14 millimeters. Which of the following is the next best step in management? A. Isoniazid and pyridoxine. B. Rifampin, isoniazid, pyrazinamide, ethambutol. B. Rifampin, isoniazid, pyrazinamide, and ethambutol. C. Dapsone, rifampin, and clofazimine. D. Interferon gamma release assay. E. Chest X-ray. Or F. Reassurance. All right, the correct answer is E. Chest X-ray. This is a case of an international medical graduate who is a recent immigrant to the United States with a 14 millimeter induration following placement of the tuberculin skin test. Recall from this table that immigrants from TB endemic countries such as Indonesia are at a higher risk for having TB. As a result, a lower induration cutoff of 10 millimeters is used to decide whether the tuberculin skin test is positive or negative. So using a cutoff of 10 millimeters, this patient's induration of 14 millimeters is considered a positive tuberculin skin test, which means that he is harboring tuberculosis. Remember that the next best step in management following a positive tuberculin skin test is a chest X-ray, and this is used to help determine whether the patient has active TB or latent TB, which is why option E is correct. An abnormal chest X-ray in the setting of a positive tuberculin skin test would be consistent with active tuberculosis, whereas a normal chest X-ray would be consistent with latent tuberculosis. Option A, isoniazid and pyridoxine, describes treatment for latent TB. It is incorrect because we haven't yet determined whether this patient has active or latent TB. Option B, rifampin, isoniazid, pyrazinamide, and ethambutol, describes the ripe therapy for active TB. It's incorrect for the same reason as option A. Option C, dapsone, rifampin, and clofazimine, describes the treatment for lepromatous leprosy, not tuberculosis. Option D, interferon gamma release assay, would have been correct if this patient previously received a BCG vaccine against tuberculosis. Remember, the BCG vaccine interferes with the results of the tuberculin skin test, but not the interferon gamma release assay. Since he never received the BCG vaccine, there is no reason to question the validity of his positive tuberculin skin test. Lastly, option F, reassurance, is not appropriate because this patient has either active or latent TB that must be appropriately treated. So again, the correct answer is E, a chest X-ray. And that concludes our lecture on tuberculosis and leprosy.